Hello, everybody. My name is John, and the purpose of this video is to relay my experience having an L5-S1 posterior and anterior approach spinal fusion. Today is about week 8 post-operatively of my procedure, and I wanted to just share my experience with you. So to start off with, I've had back pain on and off for really since college. So that would be 40 plus years. And I've just learned to deal with the back pain and the associated pain. I had really severe pain in my left leg, which would render my part of my left leg numb and tingling and throbbing. And throughout life, I basically just adapted to the pain because I really didn't want to have spinal surgery. Fast forward to life in my 60s. I'm 62 right now. And I began to notice left leg weakness. So for starters, my left lower leg, the gastrocnemius and soleus muscles in my left lower leg were slightly smaller in diameter than those of my right leg. So if you saw me in shorts and you looked at me from behind, my left calf looked a little bit thinner than my right calf. My right calf is like hairy and muscular and beefy, and my left calf just wasn't. It was kind of flat, straight, and weak. And I noticed when I would run, I was dragging my foot a little bit. So I knew something wasn't right, and it was time to go back to the doctor. So I went to my sport and spine physician, and he ordered an MRI and then also did an EMG. And what he found was I had some degenerative disc disease in all my disc spaces, which is, folks, completely normal. As we age and we go through this world with gravity and Mother Nature pushing down on us, walking around, sitting, standing, doing our daily lives, all of our disc spaces in between our vertebrae begin to narrow. And for some people, the degeneration of these gel-like discs are worse than others. And in my case, L5-S1, which is the lowermost disc space, had completely eroded so that I was almost bone on bone with nothing in the middle. And it had trapped my nerve. My S1 and L5 spinal nerves were just trapped in that space. That was causing a lack of innervation to those muscles. And when we did a subsequent EMG, which is electromyography, where they insert probes into your muscle and they ask you to flex your leg, and it sounds like a Geiger counter. You'll hear it going. I could tell that muscle just wasn't responding. So my doctor determined that I was down to 30% innervation, which is a dangerously low level. And there's no guarantee that one morning I could wake up and have complete foot drop. So we had a new MRI, and he referred me to a surgeon. The surgeon looked at my MRI, consulted with my sport and spine doctor's notes, looked at the EMG results, and we collaboratively decided that a fusion was my only option. Now, I did try to see if I could have an artificial disc replacement in lieu of the fusion, but I found out my insurance wouldn't cover it, unfortunately, and my spinal surgeon wasn't convinced he could pry apart those two vertebrae that had been fused for so many years, not fused, but degraded and demineralized so badly that he didn't feel comfortable jacking them apart to put an artificial disc in. So I ended up with an L5-S1 fusion with 2 screws at the top and 2 at the bottom and a cage. And I had what's called an anterior and a posterior approach. So first they made an incision anteriorly, and a general surgeon or a vascular surgeon creates what's called a tunnel. So they essentially move everything aside, your intestines, your great vessels, the fascia, et cetera, so that when the spine surgeon takes over, they can look down and just see directly to your spine And then they use that tunnel to dig out that diseased disc and put a spacer in. Then they close me up, flip me over while I'm still under general anesthesia, and he made 2 incisions on my back and did the rest of the cage fixation and put the pedicle screws in. So it's a pretty complex 5-hour surgery. And when you wake up from the surgery, you're not feeling too much pain because they keep you pretty well medicated. And really, the first 2 days after surgery, it wasn't painful at all because I was in the hospital for 2 days and 2 nights, and they really did excellent pain control. Now, once you go home, you are going to need help. You can't drive yourself home. You can't walk up and down any stairs without assistance. You're going to need a walker, a toilet riser, grabbers, and some stool softeners at a minimum. So let's go over that again. You need a walker. You can rent one or a friend can loan you one. I know it's embarrassing. Just go bite the bullet and get yourself a walker. You're going to need grabbers. Those are those long metal claw-like things you see with a trigger. And when you squeeze it, they clamp down and you can pick up socks, underwear, paper that you drop. Remember, for several weeks after the surgery, we can't bend. So if you drop your wallet or your car keys or whatever, your dog's leash, you ain't picking it up unless you have a grabber. So make sure. I bought 2 on Amazon for like $14 or $15. And you need a toilet riser. A toilet riser is a device that you sit on your toilet and it's got 2 handles and it raises the toilet maybe a good 8 to 10 inches, the toilet seat, because you're not going to be able to lower yourself down low enough to use that commode after the surgery. Now, because I had an anterior and a posterior approach, I was a little bit more tender than you would be if you only have the posterior approach or the lateral approach. So there's several different ways your surgeon can do this operation. Some patients need the front and back procedure, known as the anterior and posterior procedure. Some people can do a lateral procedure where they cut you open from the side and go in that way. And others do just the posterior procedure where you're on your stomach on the operating table and they do it from behind. It all depends on the type of surgery you're having, your type of issue, et cetera, et cetera. So to get us up to speed, I'm now at week 8 post-operatively, but by week 2, 3, I was walking outside in my neighborhood with just a cane or a walking stick, 3 miles. That was 3 weeks after surgery. After 2 weeks, I took a shower. Not even 2 weeks, maybe 8 days by myself. It's just really the first week you really need someone to help you get out of bed, get your underwear on, take your socks on and off, that kind of thing. The first week, I wasn't really hungry at all. I just ate those little Dixie cups of ice cream, but just be warned, you're going to be constipated. It took me 7 days before I had a bowel movement after surgery because you're going to be on oxycodone or some kind of opiate that will slow down the bowels. Plus, when the bowels are touched or moved during surgery, they don't like to spring right back to life after they've been moved and retracted by the surgeons. It takes them a few days to get back into the program. So count on having stool softeners at home, the toilet riser, and try not to eat a lot of heavy, spicy, greasy foods. That will not be your friend. Eat lightly the week after surgery. You're not going to be that hungry anyway. I have read that they don't want us using NSAIDs like ibuprofen, Advil, etc., naproxen sodium, because that can retard bone growth, and they want that fusion to occur. So really the only meds we can take are Tylenol, which does nothing for me personally. To me, it's never been an effective pain reliever. But I found Gabapentin, which is Neurontin, really helped my nerve pain. I'd say 2 weeks after the surgery, my back pain was gone, completely gone, but I started having brand new pain in both feet. And this pain really was more severe than my back pain ever was before surgery. Now, don't panic. What I've read is this is temporary because that nerve, which was trapped, is now free and it's been stretched. So, and there's a little bit of epidural scarring also that goes on. So for the first few weeks to maybe 3 months after surgery, it's not unheard of for patients to develop new lower leg foot pain. Now remember, this is for lumbar surgery. I'm not talking about cervical surgery. This is lumbar surgery. So that kind of caught me off guard. I felt so good that my back wasn't hurting, that when my feet started to hurt and it felt like pins and needles and burning, and it's worse at night when you're just laying there and you can't sleep, the 900 milligrams of gabapentin knocks it right out. And gabapentin is not an opiate. It's an anticonvulsive medication that has an off-label use to treat nerve pain. So ask your doctor about gabapentin or Neurontin for a post-op prescription. So, folks, that was my experience. Once again, I'm going to repeat the name of the procedure. I had an anterior and posterior fusion of L5-S1, and the technical name of my procedure was an ALIF, A-L-I-F, PLSF. That stands for anterior lumbar interbody fusion and posterior lumbar interbody fusion. For whatever reason, my surgeon had to go from the front and the back. So it's kind of like double surgery in one. I hope this helps you make your decision. My big advice is interview your surgeon. Please don't jump to the first surgeon you see. Get a second opinion. Have a recent MRI within 6 months. And if you can, folks, ask a nurse. If you know anybody that works at the hospital where your surgeon practices, ask him or her, the nurses, to give you the skinny on those surgeons, because I've found it's usually the nurses that know a lot. They hear when there's repeat infection rates. They hear when there's revisions that need to be made. They hear when a screw is not put in correctly over and over by some spinal surgeons. So you want to make sure you get the real deal from a nurse that works at the hospital where your surgeon practices. So, and you can do that on the down low if you can. Just ask a lot of questions. Ask your surgeon a lot of questions. Do your research. And if you can, lose as much weight as you can before your surgery. I lost about 10 to 15 pounds because I wanted to get that weight around my middle as lean as possible and strengthen my core. Because it's your responsibility to come to the table doing your part. So we shouldn't just show up to the surgeon, I'm broken, fix me. No. Your surgeon's going to look at you and go, well, you're 30 pounds overweight. Why don't you do something to show me you're committed to this surgery? And let's try not to use excuses. Oh, my back hurts, so I can't exercise. I'm eating more. I could have done that too. No. If that's your situation, cut your calories. It's simple math. Do some core exercises. Try to get as much weight off your middle as you can. That'll help your surgeon do a better job because they don't have to cut through that much abdominal fat to get to your spine. I hope this was helpful, folks. And again, go in with a positive attitude. Do all your pre-work. Have a recent MRI. Have all of the things ready at your disposal, the toilet riser, the walker, the grabber, the stool softener. And one final tip. My physical therapist told me this, and I've really appreciated it. He said, John, when you put your socks on, or your underwear, or your pajamas, or your pants, make sure you're always standing in a threshold of a doorway. That way you can hold on to either side while you lift that leg up with your grabber, or you try to slowly lean forward and get that sock up or your underwear on. It's very easy to lose your balance, especially if you're on pain medication and you're hurting and you don't want to ask somebody to help you while it's embarrassing while you struggle to get clean underwear on after a shower. So stand in a threshold of your closet or in your bedroom or somewhere where you can lean on that doorway. Okay? Expect good things to happen and happy healing. Bye-bye now.